So I'll be talking about hypofractionation in the prostate cancer, which we all know the hypofractionation is increasing role in prostate cancer. And actually it started from it is all risk categories were treating with either moderate hypofractionation or ultra hypofractionation. And there is actually an advantage of doing the hypofractionation in multiple sense. So my talk will be, let's see, I hope the slide is there but not working. So I will divide my talk to multiple hypofractionated regime and different risk categories. So for low to high risk category and also even to metastatic patient where we are using hypofractionated regime. So now we have to restart the computer, so it may take a little bit time. So let me start the talk anyway without slides. So let's talk about why the hypofractionation is become popular in prostate cancer. So one of the major reason is that alpha beta ratio of prostate gland is lower. Traditionally we were taking alpha beta ratio of 10 for every cancer, but when we did the reassessment we found, especially the Fowler's paper, that the alpha beta ratio of prostate gland is low, and because of that lower alpha beta ratio there is an advantage of giving larger dose per fraction each time. So instead of giving a 2 gray or 1.8 gray standard fractionation over protracted long period of time, we found that if we give the larger dose per fraction more than 2 gray, typically it did equally better for the prostate cancer. So in the beginning we come up with moderate hypofractionation. We all know of that moderate hypofractionation used in prostate cancer for low risk or intermediate risk prostate cancer. One of the common study of PROPHET study, which was giving 60 gray and 20 fraction. I did some of my own study for high risk prostate cancer, and it over many years time they come up with phase 1, phase 2, and now the randomized trials where we use 68 gray and 25 fractions, and that's become standard. Okay, so slides are there. So let's try to go to slide, and I will skip some of it if I've already talked. So we talk about hypofractionation, and we said what is hypofractionation. So anything more than 2 gray per fraction. And one of the example I give is 68 gray and 25 fraction, which is 2.72 gray per fraction was hypofractionation. So biological doses are actually similar what we use. However, the dose per fraction was larger, and as a result the total dose was lower. So even though total dose was lower, but because it was larger dose, then it was equivalent in biological factor using alpha beta ratio. So I mentioned about moderate hypofractionation, which is anything more than 2 gray. Typically we use 2.5 to 3 gray per fraction, but ultra hypofractionation which use somewhere from 6 gray or more, so usually more than 5 gray, but 6 to 8 gray in prostate cancer was utilized. So I mentioned already about alpha beta ratio, so I would skip this slide and I come to the advantages of the hypofractionation. So it is actually comparable tumor control, also in side effect, even though not fully, but very closer, and the quality of life. So different studies published which shows that outcomes are very similar to what the standard dose per fraction. So it is a shorter duration of treatment, which itself give a lots of advantage to the system and to the patient. We expect that the radiobiological effect will be enhanced. For example, we are talking nowadays abscopal effect of larger dose per fraction, so those advantages will be there. It is cost effective because the total number of fractions are low, so the cost to the patient is lower, even though somewhat it is because of the SBRT technique used for this purpose, then costs go a little bit higher, but not overall cost is still lower than moderate or to the standard dose per fraction. So resource utilization, this is one of the challenge in our region, that machines are too busy with the number of patients are high. So imagine we are treating nowadays 5 fraction of radiation over 13 versus 39 fraction of radiation. So we save the resources and we can treat more patient, and hospital can get advantage of being utilized for more patient. And actually I do prostate brachytherapy as well, both LDR and HDR, and I know if I face some challenge from external beam for brachy is since the SBRT come to the prostate cancer. So this is a very comparable to the best possible treatment of brachytherapy for prostate. So talk to you about some evidences, that what evidence we have. So for moderate hypofractionation, I will talk about, as I mentioned, this is the study which I designed over a period of time, but let's talk about intermediate to high risk first, then I'll go to the high risk. So PROPHET study, CHIP study, we know that they are treating in 19 to 20 fraction where 3 gray per fraction dose was used. HyPro is the another study where they use 3.4 gray per fraction in 19 fraction, and they go a bit higher dose, 64.6 gray. Also, MD Anderson used a moderate hypofractionation dose of 70.2 gray in 26 fraction using 2.7 gray per fraction. So these all randomized multi-institutional trials which compare with the standard dose per fraction, and they show the equivalence of moderate hypofractionation treatment. I would highlight a little bit more of my study. I did many years of work. So from 2004 I'm working on this dose. So 68 gray and 25 fraction, which I typically use for high risk prostate cancer. We call it CHIRP study, where we did the randomized trial. Before that was IT1, I-96, and then CHIRP study from Cross Cancer in Canada. And this study shows the equivalence of moderate hypofractionation in high risk prostate cancer. This study was also confirmed from other studies. PC5 from Montreal proven the similar outcome. Sunnybrook also from Toronto did the study, and POP-RT used the similar dose with or without pelvic lymph node treatment and found the similar results. So this is a quite established treatment nowadays for 68 gray and 25 fraction for high risk prostate cancer. It is a single phase treatment where we do concomitant SIB boost type of treatment. So pelvic lymph node get 45 to 50 gray, and prostate or gross disease got 68 and 25. I found the advantage of this dose is that when there is pelvic lymph node positive, I was giving them to this total dose as well, 68 and 25. So it's all in one plan. So that's how I prefer this for high risk prostate cancer. Now coming to ultra hypofractionation, it is not new, now it's very commonly used. So the PACE-B trial now published, so just to keep in mind that they were giving 36.25 gray in 5 fraction alternate days basis. However, because it was an SBRT plan, so the average dose to the CTV, which was prostate gland, was 40 gray in 5 fraction. They use alternate day fraction. A lot of patient on that trial was actually treated on the CyberKnife, and they do have the fiducial marker, but there are other patients who do not have fiducial marker or who was treated on the usual LINAC by SBRT. So actually this can be applied to any patient now, whatever machine facilities we have, as long as we have the verification method and planning setup for the SBRT. Then hypo-RT-PC trial was using 42.7 gray in 7 fraction over 2 weeks, so it was 2 fraction per week. This dose per fraction in this trial is a bit lower. The advantage that hypo-RT-PC trial, they took even high tier intermediate risk. PACE-B trial only took low tier intermediate risk, so there is a difference. So there is a thinking that 40 gray may not be enough for high tier or high risk patients, but however, at the moment we are following these doses unless we have the better protection for the urethra. Now other Patriot trial I want to bring to your attention, because Patriot trial use similar doses, 35 to 40 gray alternate days, but also they give another arm option of weekly fraction as well. So interesting finding come from Patriot trial from Canada is that all the weekly treatment have less side effect than alternate day treatment. So if I offer my patient both option, whether they want this 5 session of SBRT alternate days or they want to give it to weekly basis. Weekly is some patient adopt weekly because they come from far and is with less side effect and outcome was similar. So therefore I want to highlight Patriot study. That was a phase 2 randomized trial. However, it's proved the principle that weekly treatment in prostate cancer can be used for SBRT. Then the Spark trial is taking us to a little bit new direction. It's saying, okay, give the prostate gland to the same dose, but boost the focal disease, because now we have MR LINAC and we have MRI and we have PSMA and we can locate where the dominant nodule is. So they're talking about going to the higher dose per fraction. However, for our region, because we don't want to go involved into so much confusion, very simple is that somewhere from 35 to 40 gray can be used in 5 fraction, either alternate days basis or weekly basis in 5 session using SPRT and using some verification method, including either the gold fiducial or CBCT. So actually I put this slide before knowing that there is another talk on HDR brachy, so I would not just mention in here that to me brachytherapy is also ultra hypofractionated treatment, for especially the HDR, giving larger doses per fraction, and Dr. Hussain will be talking about HDR brachytherapy later on. So just this, a tri-modality study is very brand new. It's a phase 2 randomized trial from Canada, where the patient with the medium to high risk were enrolled on this study. So the reason I brought this study in here, that we need to know that even high risk can be treated with this type of treatment. So what they did actually is 2-arm where standard dose per fraction with a single HDR brachy. Typically in Canada they're doing HDR brachy before external beam, so give 15 gray of single fraction HDR followed by standard 46 gray and 25 fraction to intermediate to high risk. So even high risk pelvic lymph node was treated. Or the other arm, the second arm, which will be here more detail, is they were treated, the other arm was 5 fraction. So 25 gray and 5 fraction to prostate and pelvic lymph node, and also 1 single fraction of 15 gray to the prostate as HDR brachy. So this is a brand new study which just published as a phase 2 randomized trial. I know Vunita Kuruku was mentioning to me during my Canada visit. So I thought I should bring this attention that we are moving towards the brachy as a component and 5 session as a treatment. So this is one of the option for our patient for intermediate and for high risk. Now I want to talk about something moderate and ultra hypofractionation. So I talked to you about in the low risk, in the intermediate risk, high risk patients, where we can use moderate and ultra hypofractionation. You have choice of both moderate and ultra hypofractionation in those patients. High risk was not so much before, but there is phase 2 randomized study, and we need to wait for a little bit longer, have more data, longer data, and more phase 3 study for high risk also for ultra hypofractionation. However, moderate hypofractionation is very standard. I want to take your attention to take you to something a little bit different, which is oligometastatic or low burden metastatic prostate cases, where we all know about oligometastasis. We are treating, there are lots of data, but we being a little bit brave in Oman, and we moved to low burden metastatic disease, and there is very recent piece 1 trial come up with that there is advantage of giving radiation. So to share some of my experience from the low burden metastatic disease, where we give the prostate and pelvic lymph node 68 in 25 as we mentioned, and to the up to the lymph node of para-aortic, where we give 60 gray and 25 fraction, and the prophylactic elective nodal radiation was 45 gray. So I use the dose of 45, 60 and 68 to treat all disease up to para-aortic in these patients, and we treated 25 patients. I will show you the result. So this is the way one of the patient example. If you see the red color, which is brighter, is actually 68 gray in 25 fraction, and the green color is like up to 60 gray in 25 fraction, and elective nodal was blue color, which is like 45 gray. So we were treating this patient, and we treated 25 patients, collected their data, submitted to Astro, and they asked us for oral presentation. Unfortunately, I cannot travel. I was switching my job, but it's in the Red Journal where they showed the results. So we have shorter follow-up. We don't have a long follow-up. In the short follow-up, 2.5 years to 3 years, we are writing the full manuscript for this abstract, and we found there's none of those 25 patients have progressed, and they're all biochemically under control. But I need to say that this is not like it will be everywhere or every place, because in this center where I was working, I used the PSMA PET scan and DO hormone therapy. Okay, so I have two minutes to finish, so I'll move forward. I will skip the slides of brachytherapy because HDR will be presented later, but this is low dose red brachytherapy, not in the scheme. And we are doing that in Muscat now. We established a low dose brachytherapy in Muscat in the regions is the first one, and we have successfully treated 12 patients and continuing on. So HDR I will skip, and I will come to my few last slide. So one of the only toxicity challenge for the moderate or mainly ultra hypofractionation is the urethra, and if you draw the urethra somehow by using catheter or by using MRI sequence, we can save that, protect those side effects as well. Rectal space or space is another option to save the rectum. However, with 36.25 grain proper rectal preparation and good volume and planning, we don't see without even rectal spatial proctitis. So is it one of the tip is that prostate is only drawn, not the SVI draw for the ultra hypofractionation. Either use fiducial marker, cone beam CT, CyberKnife or Linac, both will be okay. But rectal prep is the key for all this treatment. So yes, it is doable in our region. With this, I share some of the beautiful images I took from my Oman trip for my own phone, and this beautiful country. Like to visit sometime. Thank you very much.